Good morning and welcome back for week 2. We're going to start this week with Chapter 5 Cultural Implications. And as we've already touched on a bit, your big takeaway this week is understanding that each different culture may have different cultural norms, and understanding those may better help you treat each individual patient. Starting off with some definitions, two terms that get used interchangeably a lot but really aren't are race and ethnicity. Race can be defined biologically, anthropologically, or genetically. It can be distinguished visually from one another based on physical characteristics, whereas ethnicity is a common heritage and history, sharing a worldwide worldview of thinking. Moving on, cultures are just a shared beliefs, values, practices, and cultural norms. These are the attitudes and behaviors that are culturally defined. Other definitions, one would be minority. That could be racially, ethnically, or culturally distinct groups that coexist, but are in a subgroup within that culture. And minority status. Not always fewer in numbers, but lacking political or social power, may be treated differently and discriminated against by the dominant group. One interesting factor when determining these numbers is how do we measure race and ethnicity within the United States? The primary figures are the U.S. Census Bureau. That's census every 10 years, next one coming in 2030. And these combine race and ethnical categories within the system. And the purpose, these race ethnic descriptions help the government understand the needs of its citizens. The census helps to identify disparities in healthcare along with racially ethnic lines. Another interesting factor when we talk about demographic shifts within the United States and measuring these demographic statistics is that they're constantly changing, they're constantly evolving. By 2045, the U.S. population is projected for the first time to become a majority minority nation, and that whites will be less than 50% of the culture. No one group will make up the majority. Well, no one group will have that 51% or greater percentage of the population. However, non-Hispanic whites will continue to remain the largest single group. Moving on, let's start talking about the differences between basic worldviews. And when going through these, keep in mind that these statements do not pertain to every single person within the group. Each person could have wildly different views. And we need to keep that in mind. It's good to know the basic views of each culture, but also keep in mind that each of your patient is a unique individual and will have their own unique individual requirements for treatment. The first one is Western tradition, which the United States would definitely fall under. And within that tradition, identity is found in individuality, values autonomy, independence, self-reliance. The mind and body are separate entities. Disease has a measurable cause and treatment is aimed at that cause. Time is linear and success is obtained in preparing for the future. The next would be Eastern tradition. This is based on Chinese and Indian philosophers. Family is the basis for identity. Body, mind, spirit are one entity. Time is circular and recurring. Born into a fate with a duty to comply. And disease is caused by fluctuations in opposing forces. And then we have indigenous culture. This places significance on places of humans in the natural world. The basis of identity is the tribe. The person is an entity only in relation to others. And disease is a lack of harmony between individual and environment. Our first case study. Mr. H lives with his daughter, who has become concerned about his memory. Sometimes he says he's going out to garden, but then he just disappears. Yesterday I was frantic. Then a neighbor brought him home from the shops near half a mile away. When I said, "Dad, where were you trying to go?" he said, "I don't know." Did I get there? Sometimes I think he believes he is back in Mumbai. And this is a major problem that occurs with a lot of elderly. My father-in-law had a very similar issue, and that eventually he had to go to a nursing home. And while they were able to maintain his care at home, unfortunately he kept wandering off. He was taking buses to places within the city, and it was eventually a point you can't lock a grown adult inside. He can still work the locks. You can't barricade the door. And yeah, unfortunately, it's a very sad situation that wandering can be a very real concern. Audience response question. Although his daughter has been here almost 15 years, Mr. H is a fairly new immigrant. He speaks some English and is highly educated. His daughter has mentioned he is from Mumbai, India. Which attitude would you expect him to share? Think about to our slide on Eastern tradition. For A, disease is caused by fluctuation in opposing forces. B, disease is part of one's fate and we have a duty to comply. Or C, disease has a cause and treatment is aimed at that cause. The answer is B. Disease is a part of one's fate and we have a duty to comply. Let's talk about an impact of culture. Some cultures have a very nonverbal communication, and there's an extra emphasis on body language, etiquette. Others' beliefs and values, enculturation, the teaching the children those values. Deviance from these cultural expectations can be defined as illness by other members of the group. Other definitions, we've got ethnoculturalism. This is the universal tendency of humans to think their way of thinking and behaving is the only correct and natural way. Ethnoculturalism, as we said, is the transmission of culture's worldview, beliefs, values, and practices to its members. And cultural imposition is the process in which people or groups try to impose their own values and patterns of behavior on others because they believe their way is superior. An area we've already touched on previously last week was cultural barriers to mental health services. Some cultures can be very open. They are very willing to talk to you, tell you about their problems, and work with you to help solve these problems. Other cultures will be very closed off. They are very reluctant to tell you what's going on, and they're going to be very resistant to treatment. And they can be to a lot of areas, everything from communication barriers, language barriers, to a stigma of that mental illness. Many cultures have a significant stigma on mental illness, our own included, and this can be a significant barrier for us to overcome. Some of these special at-risk populations you may encounter, everything from immigrants, refugees, cultural minorities. What is the difference between an immigrant and a refugee? An immigrant chooses to move to a new location and hopes to benefit by a change, whereas a refugee is forced to leave their homeland to escape dangerous conditions. There are going to be 5 aspects of culturally congruent care. The 5 constructs are cultural awareness, cultural knowledge, cultural encounters, cultural skill, and cultural desire. In cultural awareness, we must examine the beliefs, values, and practices of our own culture. Recognize that during a cultural encounter, 3 cultures are intersecting: culture of the patient, culture of the nurse, and the culture of that unique setting. Next would be cultural knowledge. We learn by attending cultural events and programs, forging friendships with diverse cultural groups. Learn from studying, and learning those cultural differences helps the nurse establish a rapport, ask culturally relevant questions, and identify cultural variables to be considered. Number 3, cultural encounters. These defer nurses from stereotyping, help nurses gain confidence in cross-cultural interactions, and help nurses avoid or reduce cultural pain. And that is a big thing. It is great as a nurse to get out, go work in different areas. In my own city of Cleveland, I spent much of my career working in the inner city, working for the Cleveland Clinic. It was actually one of the few places in the world that does intestinal transplants. So I'd have patients from all over the world coming to get that very intensive transplant. And just gaining experience in that, seeing the different norms, the different expectations and the requirements of treating all these patients. It really does go a long way in helping you to be a better nurse in the future. Number 4 is cultural skill. And this is the ability to perform a cultured assessment in a sensitive way. Use professional medical interpreter to ensure meaningful communication. And this is an area that I see come up in HEI a lot. I'm sure you already had it a bit in your fundamentals modules. When you're using the interpreter, make sure that you're always looking at the patient. You're not looking at and talking to the interpreter. Now they have those fancy iPads, and you actually have someone on the screen, which goes a long way. One of my difficulties was we always had those old school, it was 2 phones. You would call, an operator would pick up quickly, and you would tell them which language you'd like an interpreter for. They'd bring an interpreter on, and your patient would talk on the other phone. The difficulty comes when you have a confused, disoriented patient, getting them to understand that you're not talking to the person on the phone, you're talking to me, and vice versa. Because instead of playing telephone through the interpreter, you want to be communicating directly with that patient. And the goal is a mutually agreed therapeutic plan, culturally acceptable, and capable of producing positive outcomes. Mr. H is admitted to your unit. In your assessment, you identify some cultural patterns that may support or interfere with his health and recovery process. What can you do? Best thing would be to talk to Mr. H, talk to his daughter, understand if he read his body language, if he feels uncomfortable, try to examine what you're doing. Try to understand. We want to make this patient as comfortable as possible. That's going to go a long way to improving patient outcomes. And number 5, cultural desire. This is a genuine concern for the patient's welfare. Willingness to listen until the patient's viewpoints is understood, and patience, consideration, and empathy will be key factors in this. And finally, another audience response question. Which worldview would the nurse anticipate from a client who says, "It's important to save enough money to take care of yourself in your old age. We should not rely on anyone else to take care of us"? Would that be Eastern, Western, or Indigenous? If you said Western, you are correct, with that major focus on individuality and autonomy. Anyway, that's what we got for Chapter 5. I'll see you back here for Chapter 6 next.